Hello guys, welcome. If you can all see and hear me properly, then you can just give a thumbs up button so that we'll be able to start. Can you see and hear me? Waiting for a confirmation. Is the audio visuals clear? Hello? Can you see and hear me, guys? Is my voice okay? Clear? Okay, if we can give a confirmation, we can go into the session. We can move into the session. Okay, fine. So if you can see and hear me properly, I think I got a confirmation from Dr. Girija so that we can move into the session. So before moving into the session, let me just go through certain slides. So on Feb 26, we did have all AMD test. So we all know that. And you also know about the Iconic subscription, which where you get the benefits of both Unacademy as well as PrepLadder. And these are the FMG toppers, and congratulations to all of them. And there are a lot of new features that are coming up. So there are plenty of special class features which you can go through yourself by running into the platform. And we have multiple batches coming up. So one is going to be the NEET PG 2022 previous year questions batch. So it starts on March 2. And we also have the Focus FMG 2022 batch, which runs for 2 months, and the same course which runs for 9 months as well, from March 2 to November 2. Both of them are going to start by March 2 only. And we also do have the Target Next 2023 batch, which I'll be taking up. I think the FMG batch and the POQ batch will be taken up by Dr. Santosh, and I'll be taking up the next 2023 batch, which is going to be there for 1 year, which also starts by March 2. And again, for NEET PG 2022, we have something called as All Educators Revision batch, which also starts in March 2. It's going to run for 2 months, which will be very, very helpful for you guys for NEET PG 2022. So with a kind of a basic introduction, let us move on into the session. So the topic says that physical examination in cardiology in 60 minutes. So I'll try to be very crisp and concise and try to finish off as much as the cardiovascular examination in 60 minutes time. So what we are going to do here. So first we'll be looking at the vital signs, number 1. Then we'll be moving on into the hard sounds, then we'll be moving on to the extra sounds, and probably finally we'll move on to the murmurs, and finally we'll finish off, if possible, with the dynamic auscultation if there is time. So first, vital signs. So what are the most important vital signs we need? The first one is of course going to be the blood pressure. So that's going to be very, very important. So as far as the blood pressure is concerned, there are a few things that are important for NEET PG exams. Even for a final year perspective, this will be very helpful. But for NEET PG exams, there are certain things that you need to know. So what is the area where you're going to get a large pulse pressure? So remember, when you talk about pulse pressure, so the exact crude definition of pulse pressure is going to be the difference between the systolic blood pressure and the diastolic blood pressure. This is an old concept. We don't use the term pulse pressure as such right now. Instead, this term has been replaced with a new term called as proportionate pulse pressure. That is called as triple P. That's called PPP. That's called proportionate pulse pressure. So what is proportionate pulse pressure? It is nothing but pulse pressure divided by systolic blood pressure. Or you can write systolic blood pressure minus diastolic blood pressure divided by systolic blood pressure. So this is also what we refer to as pulse pressure. So it will be expressed in a kind of a percentage of systolic blood pressure. That's why you're going to express the proportionate pulse pressure. So if you take the crude pulse pressure, if it is supposed to be less than 20, we tend to call it as a narrow pulse pressure. If in the range of 20 to 40 millimeters of mercury, we call it as a normal pulse pressure. And if it is more than 40, we tend to call it as a large pulse pressure or increased pulse pressure. But overall, we don't use the term the crude pulse pressure right now. Instead, we use the term proportionate pulse pressure. So according to proportionate pulse pressure, if the value is less than 25%, we call it as reduced or narrow pulse pressure. If it is more than 50%, we call it as large pulse pressure. Or on the other hand, if it is if it's in the range of 25 to 50%, with the range of 25 to 50%, we tend to call it as a normal pulse pressure. So if I'm using the term large pulse pressure, means the proportionate pulse pressure is going to be more than 50%. That is what I mean by large pulse pressure. So what are the simple conditions where you get large pulse pressure? In patients who are elderly, in patients who are having hypertension, and patients who are having other hyperdynamic conditions like aortic regurgitation, patent ductus arteriosus, ruptured sinus of Valsalva, or we can say some other hyperdynamic situations like fever, pregnancy, anemia, thyrotoxicosis, beriberi, patients are having AV fistula, or patients who are suffering from Paget's disease, because Paget's disease is also a hyperdynamic state only, Paget's disease. So whenever I talk about hyperdynamic circulation, you can close your eyes and say you can see these conditions: fever, pregnancy, anemia, thyrotoxicosis, beriberi, AV fistulas. All these things are straightforward conditions that produces hyperdynamic states. So these are the conditions that generally produces a large pulse pressure. Instead, what are the conditions that produce a narrow pulse pressure? Narrow pulse pressure, in the sense the proportionate pulse pressure will be less than 25%. So this is what we call it as narrow pulse pressure. Usually happens in any patient with shock, except for distributive shock or septic shock, all the other types of shock, with special preference to hypovolemic shock and cardiogenic shock and even obstructive shock. All these things are going to produce narrow pulse pressure only, or any shock for that matters. Or patients who are having aortic stenosis, we all know there will be systolic decapitation, because of that you are going to have a narrow pulse pressure. And patients who are having heart failure, and patients who are having cardiac tamponade. So these are the conditions commonly that produces a narrow pulse pressure that you have to know at least for exams. And the third thing what you need to know is the BP difference. BP difference, which means there will be difference in BP between the arms and there will be difference in BP between the legs. So what are the conditions that produces difference in BP between two arms? Two arms means if the difference in BP is more than 10 millimeters of mercury between both the arms, it's considered to be very, very significant. So what are the conditions that produce difference in BP between two arms? So first of all, it could be completely a normal variant, or it could be some vasculitis like Takai's vasculitis, which is a large vessel vasculitis. We know it's a pulseless disease, and usually it affects one side subclavian vessel. That is why you don't have a radial pulse, and that's why perfusion will be low. That's why BP will be low, and there will be definite difference between two arms. Or even giant cell arteritis can cause, but it's very rare. Even though giant cell artery is a large vessel vasculitis, it typically affects the superficial temporal artery and ophthalmic artery and facial artery very commonly, rather than the aorta and its branches. So Takai's is very important. Even giant cell arteritis can cause that. And peripheral vascular disease, peripheral arterial disease can do that. Or patients who are having Berger disease, that is called as thromboangiitis obliterans, even they can have this kind of problem. And patients are having coarctation of aorta rarely, and more importantly, aortic dissection. For all practical reasons, aortic dissection is very, very important for exams. It produces this classic difference in BP between two arms. And even patients are having supravalvular aortic stenosis. This is another important condition, supravalvular aortic stenosis. Whenever you talk about supravalvular AS in exams, always think about Williams syndrome, which is actually a triad of hypercalcemia, Elfin facies, and supravalvular aortic stenosis. This is very, very important. And you can have BP difference between arms and legs also, which means legs will have a higher BP, arms will have a higher BP and legs will have a lower BP, or vice versa. And if the difference is more than 20 millimeters of mercury between arms and legs, it is basically considered to be significant. So what are the conditions that produce difference in BP between arms and legs? The most significant condition in this group is going to be coarctation of aorta. It's very, very important. And then you can get in aortic regurgitation, we call it as Hill sign, which is often seen in patients with aortic regurgitation. But remember, Hill sign is not a true sign. Hill sign is often considered to be a sphygmomanometric artifact. It is not a true sign in the first place. And usually based on Hill sign, you can classify as mild AR if it is in the range of 20 to 40 millimeters of mercury difference, moderate AR if it is in the range of 40 to 60 millimeters of mercury, and severe AR if the difference in BP between arms and legs is more than 60 millimeters of mercury, seen in patients with significant aortic regurgitation. And you can see in patients with peripheral vascular disease, or simply called as peripheral arterial disease also. And apart from these BP difference between arms and legs, we have something called as pulsus paradoxus, which is also very, very important. So remember, pulsus paradoxus, there are few things that are important in pulsus paradoxus. What causes pulsus paradoxus is very, very important. And what do you mean by the term pulsus paradoxus? Even though we call pulsus paradoxus is a kind of a pulse, but basically pulsus paradoxus is a BP measurement. So what is pulsus paradoxus? Normally during inspiration there will be a decrease in blood pressure. Okay, the systolic blood pressure will fall normally during inspiration. That is normal. Usually it will reduce by less than 3 to 5 millimeters of mercury. This is normal. The change will not be that great. Even if you inspire, the decrease in the systolic blood pressure will be less than 3 to 5 millimeters of mercury. If the difference, the fall in the blood pressure during inspiration, if it is more than 10 millimeters of mercury, okay, more than 10 millimeters of mercury during inspiration, if decrease is more than 10 millimeters of mercury during inspiration, this is what we refer to as something called as pulsus paradoxus. And that is why some Indian textbooks give this as a kind of a misnomer. Actually it is not, I will tell you why. But this exaggerated decline in blood pressure during inspiration is what we refer to as pulsus paradoxus. And technically it's not a misnomer, because in conditions like cardiac tamponade, in olden days what doctors found out is that when a patient is inspiring, that time they did not find pulse at all. The pulse disappeared. So why the pulse disappeared? That is because the blood pressure has dropped dramatically during inspiration. And this paradox of what they found the heartbeat, but they couldn't find the pulse at all, especially during inspiration alone. So that's why they named it as something called as pulsus paradoxus. But we know currently pulsus paradoxus is not a pulse measurement right now. It's basically a BP measurement. And how will you measure pulsus paradoxus? Just by using sphygmomanometer. And you can do it in the emergency room itself. Okay. And the patient should breathe normally. This was one of the AIIMS exam question. Patient should breathe normally, okay, during the measurement of pulsus paradoxus. And the patient should not hold the breath in inspiration or expiration, which will change the manner altogether. And the patient should breathe normally. And most of the times, the conditions that produce pulsus paradoxus will not allow the patient to hold the breath, because the conditions that produce pulsus paradoxus are going to produce severe dyspnea. Okay, patients will be in severe dyspnea and severe tachypnea. So you cannot ask the patient to hold the breath or whatever. So the patient should basically be breathing normally to measure pulsus paradoxus, which is very, very important. And what are the conditions that produces pulsus paradoxus? Number one, everyone knows almost every severe tamponade will present with pulsus paradoxus, and many pulmonary conditions like acute severe asthma, or patients are having acute severe exacerbation of COPD. Okay, all these conditions can produce pulsus paradoxus, and patients are having severe right ventricular dysfunction. Okay, and it should be very, very severe. Severe right ventricular dysfunction can produce pulsus paradoxus. Like for example, patients are having a right ventricular myocardial infarction, or patients are having a pulmonary embolism. So these are the examples where you can get a severe RV dysfunction. Because of that, you can develop pulsus paradoxus in this situation. So all these conditions are extremely important where you can get pulsus paradoxus. And more importantly, many people think, especially undergrads, think that constrictive pericarditis do not cause pulsus paradoxus, but 25% case of constrictive pericarditis can have associated pulsus paradoxus, which is something that is not important for this discussion. And then we have something called as orthostatic hypotension. Okay, that's something they will be asking you, orthostatic hypotension. So what do you mean by the term orthostatic hypotension? If the SBP decreases, if there is a fall in SBP by more than 20 millimeters of mercury, or fall in diastolic blood pressure by at least more than 10 millimeters of mercury, and it should happen within 3 minutes of standing. 3 minutes of standing. As soon as the patient stands, within the first 3 minutes itself, if the SBP falls by at least 20 or DBP falls by at least 10 millimeters of mercury, this is what we refer to as something called as orthostatic hypotension. There are plenty of causes for this which are not going to discuss. And finally, we have something called as Valsalva response. That's called Valsalva response. So generally, BP response to Valsalva is a very commonly asked question in exam. So what are the different effects of Valsalva? In the sense, what will be the normal response to Valsalva? Normal response, initially in the phase 1, the BP is going to rise. Initially, BP is going to increase, and then BP will fall during the phase number 2, and slowly it will start coming back to the baseline, and then again there will be a fall in the BP in phase 3, and again during phase 4 the BP will shoot up, and then it will come back to normal. So you have 4 basic phases of Valsalva. Phase 1, where there will be increase in the BP because of sudden constriction, okay, sudden increase in the intrathoracic pressure because you are forcefully exhaling against a closed glottis. And then you have phase 2, where there will be a fall in the BP. Then you have phase 3, this is called as release phase. Once you suddenly release, there will be a fall in the BP again, because all this time you are forcefully exhaling against a closed glottis, so the intrathoracic pressure is very high, and suddenly you have released the Valsalva maneuver and you are going into the release phase. During that time, there will be a sudden relaxation of the blood vessel resulting in transient fall. Then because of the further responses, you are going to have increment in the blood pressure, that is called as phase 4. This phase 4 is extremely important, and this is what we refer to as something called as overshoot phase. Okay, that's a very important phase because that will be lost in patients with systolic dysfunction. Suppose if the patient is having heart failure with systolic dysfunction, in patients with having systolic dysfunction, you will have the first phase, you will have the second phase, and you will have the third phase also, but the fourth phase will not be there, which means there will be something called as absent overshoot. That won't be there. That phase 4 will not be there, and that is what we get in patients with systolic dysfunction. And in patients with diastolic dysfunction, okay, what happens in patients with diastolic dysfunction? If the patient is having diastolic dysfunction, there will be a square wave response. Okay, there will be a square wave response. You know what is normal Valsalva, and if they ask you where will you get absent overshoot, you are going to tell systolic dysfunction. If they talk about square wave response, you will get in patients with diastolic dysfunction. So these are the different phases of Valsalva, which is extremely important. So as far as the BP is concerned, what are the questions you might be getting? Large pulse pressure, narrow pulse pressure, changes in the blood pressure between arms and legs, and what is pulsus paradoxus associated condition, orthostatic hypotension definition, and finally you will be needing to know about the Valsalva response to Valsalva response in terms of blood pressure. Okay, so second thing, so what we need to discuss is the pulse. Okay, whenever you talk about the pulse, you are going to talk about the rate. We all know. You are going to talk about the rhythm. So rate wise, we all know that less than 60 in adults we call it as bradyarrhythmia, and more than 100 in adults we are going to call it as tachyarrhythmia or tachycardia. Rhythm wise, you need to know whether it's a regular rhythm or irregular rhythm. And third, the most important thing is the character of the pulse. Okay, character is extremely important. So what are the different characters of the pulse you can expect? First, you need to know what is the normal pulse character. So normal pulse character is said to be catacrotic in nature. Okay, normal pulse is said to be catacrotic in nature. That is normal pulse. And what is the abnormal character of the pulses? Abnormal character of the pulses. First, we will see something called as double peaking pulse. Okay, double peaking pulse with 2 peaks. Okay, generally what is the normal character of the pulse? You'll have the anacrotic notch, then a tidal wave, percussion wave, then a tidal wave, then you have a dicrotic notch, then the dicrotic wave will start. So we can say that this is the anacrotic notch A, then you have the percussion wave P, then you have the tidal wave T, then you have the dicrotic notch D, then finally you have the dicrotic wave. Okay, so you have multiple waveforms. So normally only one wave will be palpable, and that is what we refer to as a percussion wave. That is why it is actually called as a percussion wave, because that is the one that you can normally palpate. And if you are able to palpate 2 peaks, okay, normally only the percussion wave will be the peak, but if you are able to palpate 2 peaks, that's called as double peaked pulse. And the 3 typical double peaked pulse. The first one we call it as anacrotic pulse, and the second one we tend to call it as Bispherians pulse, and the third one we are going to call it as dicrotic pulse. Okay, third one will be said to be dicrotic pulse. So what is anacrotic pulse? Anacrotic pulse means you are going to have a prominent anacrotic notch, which means you are going to have a prominent anacrotic notch. So you will be seeing both the peaks in systole only. You will be getting both the peaks in systole only. The first peak is the anacrotic notch and the second peak will be the percussion wave. Usually happens in patients with severe aortic stenosis. And the more faster you see the anacrotic notch, it is like more severe the aortic stenosis is the most important condition. And usually whenever there is a prominent anacrotic notch in aortic stenosis, there will be another character of the pulse that is called as pulsus parvus at tardus. So what do you mean by parvus at tardus? Parvus means slow rising and tardus means sustained peak, which means the pulse will be having slow rise and a sustained peak. It will not be a brisk rise and it will not be a sudden fall in the peak. It will be a slow rise and sustained peak, and that is because of LV outflow tract obstruction, which is fixed in nature in patients with aortic stenosis. Okay, then we have something called as Bisferiens pulse. Classically, Bisferiens pulse will be seen in two conditions. So what is Bisferiens pulse? You will be seeing again two peaks in systole. Okay, you will be seeing two peaks in systole. It's a double peaked pulse where you can see two peaks in systole. The classic Bisferiens pulse is actually seen in patients with combined AR and AS. Combined AR and AS. Or it can be seen in patients with severe aortic regurgitation, or it can be rarely seen in patients with hypertrophic obstructive cardiomyopathy where there is significant LV outflow tract obstruction. And remember, HCM will produce Bisferiens pulse only if at all there is significant LV outflow tract obstruction, but the characteristic pulse that you see in is HCM, that is a type of Bisferiens pulse only, that is often referred to as something called as jerky pulse. That's also something that you need to know. It's a jerky pulse, which is a type of Bisferiens pulse only, where usual Bisferiens pulse, the two peaks will be unequal. One peak will be bigger and the second peak will be smaller. But in HCM, both the peaks will be equal generally. Okay, so that is what happens here in this situation. So, but whatever may be the case, AS plus AR, severe AR and HCM, all these things can produce Bisferiens pulse, but AS alone will not produce Bisferiens pulse. Instead, AS alone will produce anacrotic pulse, or something called as pulsus parvus at tardus. Then finally, we have something called as dichrotic pulse, where there will be a prominent dichrotic notch and a dichrotic wave. So we can say, we can draw something like this. There will be a prominent dichrotic wave or a prominent dichrotic notch. Here, one peak will be in systole and the another peak will be in diastole. So whereas in anacrotic pulse and Bisferiens pulse, both the peaks are in systole, whereas in dichrotic pulse, one peak will be in systole, another peak will be in diastole. So what are the conditions that produces dichrotic pulse? Usually patients are having shock. Okay, in severe shock, generally they get dichrotic pulse. It could be cardiogenic shock or it could be hypolimic shock or whatever may be the case. But cardiogenic shock is very, very important, which can produce two peaks, one in systole, another in diastole. Probably the reason why you might get two peaks is because the initial, if for example take a patient with cardiogenic shock or cardiac failure, the initial, because the poor cardiac contractility, the percussion wave may not be prominent, but the dichrotic wave may become prominent. It is like a kind of a relativistic thing, because relatively the percussion wave becomes less prominent because of poor cardiac contractility. The dichrotic wave may appear little like prominent. So that is what we call as dichrotic pulse. Or patients who are using IABP, intra-aortic balloon counterpulsation. Why in IABP? Because IABP is something that is going to, is a device that is going to expand the balloon in diastole and it's going to deflate the balloon during systole. Because the balloon expands during diastole, there is a sudden rise in the diastolic blood pressure. So because of that, the diastolic dichrotic notch may become prominent and the diastolic wave itself, the dichrotic wave itself will become prominent. So you will get two peaks in systole and diastole, one peak in systole and another peak in diastole. This is what we call as dichrotic pulse. And apart from that, there are many other abnormal pulse characters. So one is double peaked pulse, I told you. Apart from that, we have alternating small and large volume pulse. Alternating small and large volume pulse. So this is something that can happen in two situations. One, we call it as pulsus alternans, and the second one we tend to call it as pulsus bigemini. In both these conditions, you will have alternating large and small volume pulse. Pulsus alternans typically happens in the setting of a severe left ventricular failure. where the mechanism is that of a Frank Starling law only, nothing much. And pulses bigeminy, we all know it happens the setting of a ventricular bigeminy. It happens at the setting of a ventricular bigeminy. When you talk about ventricular bigeminy, always associate that with digitalis toxicity. Okay, that is what is important for exams. And how will you differentiate between pulses alternates and pulses bigeminy? Both will have alternating small volume and large volume pulse, but alternates will be regular in nature, whereas bigeminy will be irregular in nature. It will not be regular. That is why one of the important causes of regularly irregular pulse is bigeminy. Remember, you all know irregularly irregular pulse is always atrial fibrillation, but cause of regularly irregular pulse is going to be bigeminy, which is an extremely important point. So this is the second abnormal character of the pulse. Third abnormal character of the pulse, if you ask me, that I would say it's a collapsing pulse. Okay, collapsing pulse. Okay, this is another kind of abnormality that you generally look for. Okay, so what are the conditions where you get a collapsing pulse in the first place? Collapsing pulse is something that you can get in patients who are having hyperdynamic circulation. So what do you mean by the term collapsing pulse in the first place? Just hold on. Collapsing pulse in the first place. Usually what happens, your pulse will rise and they will fall. This rise and fall will be, like you will be able to detect it. So the how much it rises, how much it's rising and how much it's falling. So that rise and it's hitting your finger and it's falling and it's receding. So both these things will be able to be found out very easily. In collapsing pulse, there will be a brisk collapse. In the sense, what happens in collapsing pulses, the rise will be brisk, at the same time the fall also will be very rapid. The rise will be brisk and fall also will be very rapid. This brisk rise and sudden brisk fall is what we called as a collapsing pulse. And the reason for collapsing pulse can be of two things. One is we called as central and peripheral runoff. So there are some conditions which produce a central and peripheral runoff. So why you get peripheral runoff? Peripheral runoff you get generally because of vasodilatation. Because of vasodilatation, the blood goes very rapidly into the peripheral circulation, doesn't stay in the central circulation. Because of that, you might get this fast moving blood so that it recedes away from central circulation because it moves very rapidly into the periphery because of areas of low resistance, and that's why you get a rapid collapse. That's peripheral runoff because of systemic vasodilatation, which is resulting reduced systemic vascular resistance. And what about central runoff? Central runoff means there is a central structure that is in the heart itself where there is a communication between two chambers. Like for example, your aorta and the ventricle, or probably with your pulmonary artery and the aorta. Likewise, there are some communication in the heart which is causing a rapid backflow of blood back into the heart during diastole, not in systole. Remember, VSD is an example where it produces blood movement during systole but not in diastole. Because we are talking about a runoff here, it should be a diastolic condition that produces movement of the blood from central circulation into some other chamber. The best example of that is aortic regurgitation, because during diastole, in aortic regurgitation, the blood doesn't stay in the aorta, it comes back into the heart, and that is why there is a central runoff. And then apart from that, you can see conditions like patent ductus arteriosus, where the blood moves during both systole and diastole, and there is a movement of blood from aorta into the pulmonary artery during diastole also. That is the reason. And again in RSOV, there will be a blood movement from aorta, especially from the aortic root into one of the ventricular chambers, most commonly a right ventricle. That's called as ruptured sinus of Valsalva, or probably you can get that with AV fistula. Even in AV fistula, there is a continuous movement of blood during both systole as well as diastole. That's why in AV fistula also you can get the central runoff. So I told you these are the conditions which produces central and peripheral runoff. But in these conditions, the central runoff becomes very, very important. And there are some conditions which produces typical peripheral runoff only. There are some conditions which can produce only peripheral runoff. It doesn't produce central runoff, they produce only peripheral runoff, where because of the significant decline in peripheral vascular resistance or systemic vascular resistance. What are the conditions? You can get in anemia, you can get in fever, high fever, there will be significant vasodilatation, sepsis patients or pregnant individuals or patients who are thyrotoxic. In all these situations, your peripheries will be vasodilated because of decline in systemic vascular resistance. there will be significant peripheral runoff, which means during diastole, the blood doesn't stay in the central vasculature and it runs away into the peripheral vasculature because of low resistance. And that is why you get a sudden brisk fall in the pulse, and that's what we call it as collapsing pulse, or more popularly, when you talk about your aortic regurgitation, it is also called as Watson's water hammer pulse. It's called as collapsing pulse, or especially in aortic regurgitation, you can call it as Watson's water hammer pulse. So the sense pulses, collapsing pulse or pulses alternance is not very specific for AR. It can be seen in multiple other conditions also, which is extremely important to understand. And yes, so this is all about the collapsing pulse. And I think there are other things that you need to look for when you talk about the pulse. You need to look for synchrony between the two arms and the legs. For example, there is something called radial synchrony and radio-femoral synchrony. At the same time, you need to look for the pulse volume, whether it's a large volume pulse or small volume pulse. And finally, you need to look for condition of the vessel wall, where we demonstrate something called as Osler sign, which is beyond the scope of the current discussion. You need to demonstrate something called Osler sign clinically to find out that there is any problem in the vessel wall, or is there any abnormal condition of the vessel wall. So this is all about the pulse. Then when it comes to jugular venous pressure, it's a very important topic as well, jugular venous pressure. And remember, it's very difficult to explain everything about the jugular venous pressure in a matter of 5 minutes or 10 minutes, but I'll tell you the important waveforms only and what are the important problems with the jugular venous pressure. Okay, so what is the normal jugular venous pressure? So normal jugular venous pressure is approximately going to be 5 to 8 centimeters of water. Okay, 5 to 8 centimeters of water. This is a normal jugular venous pressure if you use centimeters of water. And you can actually convert that into millimeters of mercury also if you want, but normal is going to be 5 to 8 centimeters of water. So this is a normal jugular venous pressure. And generally, if you want to convert centimeters into millimeter, 1.3 centimeters of water will generally be equivalent to 1 millimeters of mercury. So normal JVP in terms of millimeters of mercury will be up to 7 millimeters of mercury is considered to be normal generally. If you want to go up to millimeters of mercury, the mean is up to 7 millimeters of mercury. Okay, and there are multiple conditions of elevated JVP, but let us see only the waveforms. So what are the waveforms? So you have the A wave, you have the C wave, and you have the X descent, and you have the V wave, and you have the Y descent. V wave and you have the Y descent. Okay, so this is A, C, X, V, Y. And many times in certain textbooks they will give X and X dash also. No need to confuse that. Just take it as X descent. And what are the timing of these different waveforms? We know A is due to atrial contraction, and C wave is due to isovolumetric ventricular contraction, and X descent is due to ventricular systole, especially during the rapid ejection phase. Okay, ventricular systole during the rapid ejection phase. And V wave is technically due to venous filling of the atrium. Venous filling of the atrium. And Y wave is basically due to ventricular filling. After opening of the mitral and tricuspid valve, there will be ventricular filling, movement of the blood from atrium into the ventricles. That is what is going to produce the Y descent. And what are the correlations with the heart sounds? Generally, A wave correlates with the fourth heart sound, C wave correlates with the first heart sound, and generally the beginning of, near the peak of the V wave, you are going to get the second heart sound, and during the Y descent, you are going to get the third heart sound. Okay, these are the general correlations as far as the heart sounds are concerned. You want to correlate with the heart sounds. And remember, whenever you see JVP, always correlate with the carotid pulse or heartbeat. That is very, very important. Okay. Apart from that, what are the problems that you can get? And normally speaking, A wave is something that's going to be bigger than the V wave. That's a normal morphology. Usually, A will be bigger than V, and your X descent will be deeper than the Y descent. This is normal morphology. A will be bigger than V, and X descent will be deeper than the Y descent. So this is normal morphology, and that's how I've exactly drawn here also. And what are the problems that you can get with the JVP? So first, let us see about the descents. So you can get problems of the A wave. So what are the problems of A wave, which is very important for exams? First, you can get a large A wave. Okay, large A wave. So what are the conditions where you get a large A wave? Traditionally, you will get in patients with tricuspid stenosis and pulmonary hypertension. So anything that produces pulmonary hypertension, you might be able to get a large A wave, including pulmonic stenosis. This is something that many people don't write usually in exam, but even pulmonic stenosis can result in large A wave. And one special condition, if you want to write, there is something called Bernheim syndrome. Okay, Bernheim syndrome. Bernheim syndrome. Usually this happens in patients with severe left ventricular hypertrophy, like in patients with severe aortic stenosis or in patients with severe hypertrophic cardiomyopathy. In this condition, because of the bulge of the septum during systole, what happens is there will be a bulge of the septum from left side towards the right side, because the LVH is so severe and the pressure generated in the left ventricle is so high that the septum will shift towards the right side, and that will produce a kind of a like increased RV pressure, and that will result in elevated A wave in the JVP, and that is what we call as Bernheim effect or Bernheim syndrome, which is actually quite rare. It is not common. Okay, this is large or prominent A wave. Then we have something called as Canon A wave. Canon A wave. Canon A wave has a special definition. If the height of the A wave is more than 16 millimeters of mercury, more than equal to 16 millimeters of mercury, we call it as Canon shot or Canon A wave. Remember, in large or prominent A wave, the height of the A wave will be less than, or the pressure of the A wave will be less than 15 millimeters of mercury only. It will not be more than equal to 16. In Canon A wave, it will be more than equal to 16 millimeters of mercury, and that is the definition of a Canon A wave. The A wave pressure is what we are talking about. So whenever you see a Canon A wave, it indicates that atrium and ventricle are contracting together, or we can say atrium is contracting against a closed tricuspid valve. That is why you get a Canon A wave. And the Canon A wave could be either a regular Canon A wave or it could be a irregular Canon A wave. Irregular Canon A wave. So regular Canon A wave typically is seen in patients with SVT, especially a PSVT like AVNRT. That is the condition where you see a Canon A wave. Whereas irregular Canon A wave is seen in patients with atrioventricular dissociation. That is the place where you get a irregular Canon A wave. So what are the conditions that produce AV dissociation? For exams, you need to know only two conditions. One is complete heart block. Okay. It's a bradyarrhythmia that produces AV dissociation, and second, we have a ventricular tachyarrhythmia or a PVC or frequent PVCs is what we can say. So these are the conditions that produces irregular Canon A waves. Remember, a tachycardia that produces AV dissociation is VT, and a bradycardia that produces AV dissociation is going to be your complete heart block. Both are extremely important, and you can get something called as absent A wave in atrial fibrillation, and that's it. So absent A waves are also very, very important. And absent A waves typically you will be getting in patients with atrial fibrillation. Remember, even if the patient is having pulmonary hypertension, like in conditions like mitral stenosis, if you have a atrial fibrillation associated, you should comment that the patient is having a absent A wave only. And this is extremely important for exams. Most of the time they will be asking about A wave only. And what about the abnormal X wave? So because we have something called as X descent, and when it comes to X descent, most of the times they'll be asking you about what are the conditions where you have a reduced X descent or a obliterated X descent. The most important condition that produces reduced X descent is tricuspid regurgitation, because X descent is due to ventricular systole that is pulling the atrial floor downward, expanding the atrial cavity, resulting in fall in pressure. But in tricuspid regurgitation, during ventricular contraction, even though the atrial floor is pulled downwards, that fall in pressure is counteracted by the movement of the blood or regurgitant blood into the atrium. So that's why you will have obliteration of the X descent. And second condition is going to be atrial fibrillation, where the atrium fails to relax in atrial fibrillation. That is the main reason why you're going to get a obliterated X descent. And most important is tricuspid regurgitation in this situation, where you can get a prominent X descent. Okay, prominent or a deep X descent is found in patients with tamponade, cardiac tamponade. Cardiac tamponade is a condition that produces a deep X descent or a prominent X descent. Sometimes it can be seen in patients with constrictive pericarditis also, but the most important condition that produces a prominent X descent is going to be your cardiac tamponade. And then we have abnormalities of the V wave. Abnormalities of the V wave. So what are the conditions where you can get a large V wave? This will be the exam question. What are the conditions where you get a large V wave? So V wave is basically due to venous filling of the atrium. So apart from SVC and IVC, what else can fill the atrium? Apart from SVC and IVC, what else can fill the atrium? It can be your regurgitant blood from the ventricle that can fill the atrium. It can produce extra filling of the atrium. That is called tricuspid regurgitation. And apart from that, you can get during some shunts like AST where left atrium is filling the right atrium. It's a shunted blood, or sometimes it could be anomalous pulmonary venous connection. It could be total or partial anomalous pulmonary venous connection. So this anomalous pulmonary veins means some pulmonary veins normally should drain the left atrium. In these patients, abnormally they will be draining into the right atrium. So right atrium is getting excess blood. That's why you will get a large wave. Or rarely in patients with constrictive pericarditis, in patients with congestive cardiac failure, in these situations also you might be able to get a large wave, which is also an extremely important point. And there is something called abnormalities of the Y descent. Okay, what are the conditions which produces a steep Y descent or a prominent Y descent? So generally steep Y descent or prominent Y descent will be seen in patients with tricuspid regurgitation and will be seen in patients with constrictive pericarditis. Both are extremely important. And apart from that, reduced Y descent or attenuated Y descent or a small or a slow Y descent, you can call it in any way, attenuated, slow, small Y descent. So will be typically seen in patients with tricuspid stenosis, or it can be seen in right atrial myxoma. Okay, something is obstructing the blood from moving outward. That's why like the Y descent is not happening. Or it can happen in patients with cardiac tamponade. So these are the conditions where you need to understand that there will be a small Y descent. Small Y descent means there is inadequate ventricular filling. We know Y descent is due to ventricular filling. So what is going to stop your ventricle from getting filled? A tricuspid stenosis, or a tumor in the right atrium like right atrial myxoma, or it's going to be tamponade where fluid is compressing the right atrium, which is not allowing the blood from moving, or fluid is compressing the ventricle so that it's not allowing the blood to move from atrium into the ventricle. So these are the conditions which produces a small Y descent. So you need to understand in this perspective only A wave abnormalities, X descent abnormalities, V wave abnormalities, and finally we also have something called as Y descent abnormalities. And you have epidojugular reflex. So what is epidojugular reflex? When you are going to press the right hypochondrial region, if there is increase in the JVP by more than 3 centimeter and if it is sustained for at least more than 15 seconds, this is what we call as epidojugular reflex. Both are important. Remember, it should rise by more than 3 centimeters from the baseline value, and it should increase by more than and it should be a sustained rise for more than 15 seconds also. So this is what we call as epidojugular reflex, which typically happens in patients with CCF, especially those who are having right ventricular failure. In fact, it's considered to be a poor man's fluid challenge. If they have a CCF or RVF, you are going to have a positive epidojugular reflex. And one other conditions what they will be asking you is where you will have a elevated JVP, but you will have an absent epidojugular reflex. Okay, what are the conditions? Where epidojugular reflex is completely absent. The most important condition is SVC thrombosis. There are plenty of conditions, but this is the one thing they will be expecting you in exams, that is SVC thrombosis. If the patient is having SVC, superior vena cava obstruction, the JVP will be elevated, but you will not be able to get any change with regards to epidojugular reflex, because the pressure that is happening in the pressure change in the right atrium is not transmitted into the JVP. That is why you will not be able to see any epidojugular reflex in patients with SVC thrombosis. And if they tell where you will see JVP in the form of M's and W's, this is a favorite question in the exams. M's and W's, where you will see in constrictive pericarditis. That is because of both prominent X descent sometimes and prominent Y descent also. You will be able to see this W and M. So whenever they ask you about where you will see M's and W's in JVP, that again tells you that the patient that you will see in patients with constrictive pericarditis only. So 3 important vital signs is something we have finished. So one is going to be the blood pressure, and second is pulse, and the most important thing about the pulse is the character, and then we finished off the jugular venous pressure also. Now it is time that we move on to the heart sounds. Okay, heart sounds. Heart sounds means we have first heart sound, second, and more importantly, let us move to the apical impulse first. Okay, even before going to the heart sounds, let us finish off the apical impulse. Okay, what is the normal location of the apical impulse? Normal location of apical impulse will be in the left 5th intercostal space, slightly medial, maybe like 0.5 to 1 centimeter medial to the midclavicular line. Very important. usually in the left fourth or fifth, but in exam you answer fifth intercostal space, slightly medial, okay, like 0.5 to 1 centimeter medial to the mid-clavicular line. So this is the normal location of the apical impulse, and usually apical impulse diameter should be less than 2 centimeter or approximately only 1 intercostal space. The diameter of the apical impulse should be less than 2 centimeter and it should be only 1 intercostal space usually. Okay, so location you have to know what is the normal diameter and how much it should be there. All these things are extremely important. Okay, usually apical impulse will correlate with isovolumetric ventricular contraction. Again, that's very important point, which means it's going to correlate with the C wave of the JVP. Apical impulse will correlate with isovolumetric ventricular relaxation, and the best position to look for apical impulse is the left lateral position. Left lateral position is the best position to look for the apical impulse. And what are the abnormalities of the apical impulse? It is called as hyperdynamic apical impulse, okay, or you can call it as a sustained apical impulse or a heaving apical impulse. So what do you mean? What are the conditions where you see hyperdynamic apical impulse? What do you mean by hyperdynamic impulse? It is increased amplitude of apical impulse. Amplitude of apical impulse will be high, but it will be normal in duration. Duration will be normal. Okay, so usually it indicates hyperdynamic states. I told you what are the hyperdynamic states, like fever, hyperthyroidism, anemia, pregnancy. All these are hyperthyroid states. Apart from that, you can see in patients with MR, AR, VSD, okay, patent ductus arteriosus. These are the conditions which are going to produce hyperdynamic apical impulse. Apart from the routine hyperdynamic states like fever, pregnancy, hyperthyroidism, beriberi, okay, AV fistulas. Any other condition you can say, but these are important pathological conditions that you need to know. And sustained apical impulse. What do you mean by sustained apical impulse? Here the patient will be having increased amplitude. At the same time, the patients will be having increased duration of apical impulse also, which means it will be persistent for more than 2/3 of the systole. It will be persistent for more than 2/3 of the systole. Or alternative definition is, when you are palpating both the carotid and the apical impulse simultaneously, you will be able to feel the apical impulse even after the carotid upstroke. Even after the onset of carotid pulse also, if you are able to feel the apical impulse, that is what we refer to as a sustained or a heaving apical impulse. Usually hyperdynamic apical impulse indicates volume overload to the left ventricle, whereas your sustained or heaving apical impulse will tell you that the patient is having a pressure overload. Okay, it will tell you that the patient is having a pressure overload. Okay, so what are the conditions? Example, it can be seen in patients with aortic stenosis, it can be seen in patients with severe hypertension, it can be seen in patients with hypertrophic cardiomyopathy also. Okay, when will you call it as left ventricular hypertrophy? Based on apical impulse. Remember, if the apical impulse diameter is more than 2 centimeter, or if the apical impulse is located beyond 1 intercostal space, which means it's palpable beyond 1 intercostal space, or if there is a shift in apical impulse, okay, to down and out. Okay, this is called down and out shift of apical impulse. This is also a sign of LVH. Or normally apical impulse should be located within 10 centimeter from the mid-sternal line. Okay, there is something called mid-sternal line. So you have a mid-sternal line here. Normally apical impulse should be located within 10 centimeter from the mid-sternal line. Okay, if the apical impulse is located beyond 10 centimeter from the mid-sternal line, okay, if the apical impulse is located beyond 10 centimeter from the mid-sternal line, this is also a definition of left ventricular hypertrophy. So using apical impulse itself, you will be able to say whether the patient is having LVH or not. And apart from that, if they ask you in exam where will you see double apical impulse or triple apical impulse or even quadruple apical impulse, whatever may be the case, so usual answer will be hypertrophic cardiomyopathy. So that's what you need to answer. Double, triple apical impulse, always go for hypertrophic cardiomyopathy. That is because of dynamic LVOT obstruction, and explanation of these concepts is beyond the scope of the current discussion. If they talk about ectopic pulsation or ectopic apical impulse or ectopic pulsation, usually it will be LV aneurysm. Usually happens after a complication of ST elevation myocardial infarction. That is LV aneurysm. And generally, where will you see parasternal heaving? It can be graded separately also, I'm not going to discuss now, but parasternal heaving is commonly associated with right ventricular hypertrophy, that is RVH. Okay. Apart from that, in palpation, you will be able to feel the thrill. You know what is thrill? Thrill is nothing but a palpable murmur, and you will be able to see other pulsations also. So apart from that, when you talk about palpation, you need to comment on the pulsations. Generally, if you see pulsations in the second right intercostal space, if you're able to see pulsation, generally that indicates a aortic aneurysm, especially an ascending aortic aneurysm. If you see pulsations in the second left intercostal space, it usually indicates a pulmonary artery dilatation. It indicates a pulmonary artery dilatation. So these are the important things, and apart from that, we know thrill is nothing but a palpable murmur. So for a murmur to produce a thrill, usually you should have at least grade 4 murmur and above. The murmur grade should be grade 4 and above. Okay, both systolic and diastolic murmurs can produce a thrill, but the only rule is that the murmur should have a grade of at least 4 and above. Then only you can produce a thrill. Thrill is nothing but a palpable murmur. So when talk about palpation, these are things that you need to look for. So now we are going to auscultation. Auscultation wise, we have first is heart sounds. Heart sounds wise, we have first heart sound and we have something called as second heart sound. So first heart sound is made of two components, M1 and T1. Okay, which means you have a mitral component which happens first and a tricuspid component which happens next. Usually the interval between M1 and T1 is going to be just very, very small, that is 20 to 30 milliseconds or not more than that. Okay, usually this very small gap is something that we cannot see with our routine eyes, routine ear, we cannot hear with the routine ears. Routine auscultation, you will not be able to see the split of the M1 and T1. Generally, S1 is heard as a single sound only. Very rarely in conditions like right bundle branch block. Okay, in conditions like right bundle branch block, where there will be a delayed T1, or in patients with atrial septal defect, where you'll have a delayed T1 again, or in patients with Epstein's anomaly. Okay, Epstein's anomaly. Okay, again because of delayed T1 in these situations. In these situations, you will be able to see a split S1. Okay, split S1. But apart from that, it's very difficult to see a split S1. Generally, very difficult to see a split S1. Very difficult to hear a split S1. These are the conditions that generally produce a split S1. And especially in Epstein's anomaly, one of the leaflets of the tricuspid valve will be very, very abnormal, and that abnormal tricuspid valve leaflet will produce a very characteristic sound that is very commonly asked in exam called as sail sound. That's something very important for exams. Okay, usually in INA-CET exams also tend to ask this question, sail sound or a sail first start sound or a sail kind nature of a first start sound. Where you see that is something that is seen in Epstein's anomaly. And more importantly, remember the split of the first start sound is not at all important. The most important is loudness or softness of the first start. So the intensity of the first start sound is going to be the key in exam. So where will you get a loud first start sound? Loud first start sound is seen in patients with MS and TS. The most important condition is MS, or we can clearly say it's rheumatic heart disease. That is where you're going to get a loud heart sound. But remember, only in early rheumatic heart disease you will be able to get a loud first start sound. Once the RHD progresses and if it becomes a severe MS, you will not be able to see the loud first start sound. You will be able, once the valve becomes completely calcified, you will be able to hear only a soft first start sound only. And especially in hyperdynamic situations. I mean, whenever talk about hyperdynamic means it's fever, anemia, pregnancy, beriberi, thyrotoxicosis, AV fistula, Paget's. All these are hyperdynamic states. Hyperdynamic states generally produce loud first start sound. And short PR interval, especially if it is less than 120 milliseconds, we call it as short PR interval, and that is what we call it as short PR. And in short PR, you will be able to see a loud first start sound. And whenever there is increased flow across AV valves, increased flow across atrioventricular valves, that is because whenever there is more blood flowing across the atrioventricular valves, you will have more opening of the AV valve, so that the closure will be more noisy. So that is why you can get a loud first start sound. Generally, it happens in patients with the ASD also. There is more flow across the tricuspid valve. In VSD also, where there is more flow across the mitral valve, and even in PDA also, there is more flow across the mitral valve. That is the reason why you are going to get a loud first start sound in these situations. And where will you get a soft first start sound? The most important condition, I would say, is a calcified valve. Okay, calcified mitral or a tricuspid valve. Remember, even in a rheumatic heart disease, if the mitral valve is calcified, you will not be able to get a loud first start sound. You will get a soft first start sound only. And second, in patients with congestive cardiac failure, because the force of contraction of the ventricle will be less, because of that the force of closure also will be less. So you are going to get a soft S1 only. And patients are having prolonged PR interval. Prolonged PR means more than 200 milliseconds or more than 0.2 seconds. You are going to get a soft first starts only in patients who are having MR or AR. Okay, MR or AR will get a soft first starts only, especially if it's a severe AR or if it's an acute AR. In this condition, you will be able to get a soft first starts on. These are important. MR means there will be poor coaptation of the valves. In MR, there will be a leaky, floppy valve. So the valve will not hit at all to produce a heart sound in the first place. And where will you get a variable intensity of first heart sound? Usually seen in patients with atrial fibrillation because of different lengths of cardiac cycle. You will be getting a variable first heart sound only. And what about second heart sound? Second heart sound, usually you can quantify in the terms in the form of two things. One is called as intensity of second heart sound, and second one is going to be the splitting of the second heart sound. Intensity of second heart sound, and we have something called as splitting of the second heart sound. So where will you see increased because we know second heart sound is made of A2 and P2, and many a times we'll be able to hear the split properly. Okay, second heart sound. So both are important for second heart sound. Whereas in first heart sound, the intensity is more important than the split. Whereas the second heart sound, both intensity and split are important. So which means you can see conditions which produces increased intensity of A2. You can see conditions that produces reduced intensity of A2. You can see conditions where you will see increased intensity of P2, and you will be able to see conditions that produces low intensity of P2. So what are the conditions where you will see increased intensity of A2? You will be able to see in patients with hypertension. You will be able to see in patients with coarctation of aorta. You will be able to see in patients with ascending aortic aneurysm. Okay, you will be able to see in patients with transposition of great vessels, and you will be able to see in patients with supravalvular aortic stenosis. So basically, technically, what are the conditions that produce increased A2 intensity? It's very simple. A2 closes if there is increased pressure in the aorta. Okay, very simple. So what are the conditions that produce increased pressure in the aorta? So A2, the aortic valve will close faster. Hypertension, because of increased afterload and increased pressure in the aorta. During closure, the valve closes faster and more forcibly. In coarctation of aorta, similar condition. There is obstruction in the aorta that will produce increased pressure within the aorta that will close the valves faster and more noisily. And in ascending aortic aneurysm, there will be dilatation of the aortic root. Because the dilatation of the aortic root, the recoil will be forcible, so that closure will be faster and noisy. And likewise in supravalvular aortic stenosis also, the obstruction is above the aorta. Same problem. So the closure will be more rapid and more noisy, and that is why you are going to get a increased intensity of the A2, second heart sound. Where will you get reduced intensity of A2? You will get in a valvular aortic stenosis. So many people will question this valvular aortic stenosis. Why in MS you get a loud S1, but why in AS you are getting a soft S1? Because the mechanisms of MS and AS are different. In rheumatic heart disease, MS happens due to thickened leaflets that produces more noise. Whereas in valvular AS is basically due to calcification, degeneration of the valve. Because of calcification, you will not be able to get a loud A2, and you will get a soft A2 only. And in patients with aortic regurgitation, there will be a floppy valve, so you will not be able to get a noise. So you are going to get a reduced intensity of A2. And what about loud P2? Loud P2, typical example is pulmonary hypertension. Okay, and in patients with supravalvular pulmonic stenosis, you are going to get a loud P2. But most important is pulmonary hypertension only. And what about reduced intensity of P2? Reduced intensity of P2 you will get in valvular pulmonic stenosis. As we discussed, like valvular aortic stenosis, valvular pulmonic stenosis is going to produce a reduced intensity, and like AR, here PR is going to produce low intensity of second heart sound, pulmonary component of the second heart sound only. And transposition of great vessels also can produce a reduced intensity of pulmonary component of the second heart sound. And what is the most interesting point here is TGA is one thing that produces increased A2 intensity and reduced P2 intensity. That's where the point is. Okay, so TGA is one of the only condition that produces increased A2 intensity, and at the same time it will be producing reduced P2 intensity. Extremely important point. Okay, and another small point with regards to PS, that is this PR, that is pulmonary regurgitation. There are two types of PR. Whenever you talk about PR, you will have something called as hypertensive PR hypertensive PR. Second one is called as normotensive PR, which means because of pulmonary hypertension, okay, you are going to get a pulmonary regurgitation. You know that murmur, that PR murmur due to pulmonary hypertension is called by a specific name called as Graham-Steele's murmur. And normotensive PR means there is no pulmonary hypertension, but still you have a PR. This is a de novo pulmonary regurgitation because of floppy valve. And usually in hypertensive PR, you will have a loud P2 only. That's a very, very important point because there is pulmonary hypertension. But in a normotensive PR, you will have a soft P2, that is low intensity of P2. It's very important. The PR I'm discussing here is primary PR, or we call it as a normotensive PR. But if the patient is having pulmonary hypertension and because of you are having PR, that's hypertensive pulmonary regurgitation, and in that situation you will have a loud P2 and not a soft P2, low intensity of P2. Then coming to split. Okay, split of the second heart sound. Okay, second heart sound split. So normally what happens, you can see in inspiration and expiration what happens normally. During inspiration, split will be usually heard, okay, and expiration split will normally not heard, and this is normal. This is normal. Normally itself during inspiration you will hear the split, and expiration you don't hear the split. Why in inspiration? Because during inspiration there will be more blood flow into the right ventricle by default, and that will produce more flow across the pulmonary valve. So the pulmonary valve will close later. So in inspiration, A2 and P2 will be widely separated because of late closure of the pulmonary valve, because of more blood flow into the right ventricle and then into the pulmonary valve. So normally itself during inspiration you will be able to hear the split, and expiration you will not be able to hear the split because reverse happens in expiration. Whereas in patients who are having wide split, you will be able to hear the split during both inspiration and expiration. Whereas if you have a narrow split, you will not be able to hear the split in both inspiration as well as expiration. If you want to know what is reverse split or paradoxical split, you will be able to hear the split in expiration but not in inspiration. This is actually the definition of clinical definition of reverse split, or what we call as paradoxical split. So what are the conditions that produces wide split or increased splitting, or you can call it as wide split? So typically you will see in patients with right bundle branch block, because of RBB there will be delayed depollution of right ventricle, and because of that there will be delayed closure of the pulmonary valve also. And in patients who are having early A2, so what are the conditions where you can get early A2? Remember, A2 and P2 should be there. Either if you have a delayed P2, you can get a wide split, or if the patient is having early A2 also, you will be able to get a wide split. So early A2 you can get in MR or you can get in VSD. In both MR and VSD, there are two outlets for the left ventricle. So in MR, one outlet is aorta and another outlet is left atrium, and in VSD one outlet is aorta and another outlet is going to be right ventricle itself. Because of two outlets in MR and VSD, the amount of blood going into aorta will be lower, so the aortic valve will close earlier, and that is why you get early A2. If you get early A2 means the split will widen. Or you can get another condition that produces late P2 is right ventricular outflow tract obstruction, like patients are having pulmonary hypertension or pulmonary stenosis or some RVOT obstruction. Some RVOT obstruction will be resulting in very late P2 because right ventricle will contract for a longer period of time. That's why you will get a late P2 resulting in a wide split. And typically if they ask you what are the conditions that produces fixed split. Fixed split. Okay. So fixed split. So what do you mean by fixed split? The split does not vary with Valsalva or any other dynamic maneuvers. But most importantly Valsalva. If you do Valsalva, things will change. But if it doesn't change, if it's a fixed split, if it's fixed, whatever may be the character, if the split doesn't change with Valsalva, we call it as fixed split. Technically in exam they will be asking you wide fixed split only. So why wide fixed split, especially because it's associated with the ASD. What do you mean by wide fixed split? This split will not change. The nature, whatever the duration and whatever the splitting pattern, inspiration or expiration is not going to change based on your Valsalva. That's what we call it as wide fixed split. What are the conditions that produces wide fixed split? ASD, number one condition which produces a wide fixed split. And second, in patients who are having right ventricular dysfunction, especially if they are having RVF, severe RV dysfunction, you will not be able to change the volume based on the preload that is coming into the right ventricle. So that is the reason why these are the two conditions that produces fixed split, or more technically we can call it as a wide fixed split. But whenever you talk about wide fixed split in exam, it's almost always about atrial septal defect only. And what are the conditions that produces narrow split or a reverse split? I mean, both have similar conditions, similar mechanisms only, but more importantly, it's very important to know about reverse split. I'll come back to narrow split in a while. Reverse split. So first condition is going to be left bundle branch block. Because of delayed deportation of the left ventricle, you will get a delayed A2 only. If you get a delayed A2, and sometimes A2 will cross P2 and go, and that is what we call it as fixed split, reverse split. Reverse split means P2 A2. This is reverse split, and this happens in left bundle branch block, or it can happen in patients with severe LV outflow tract obstruction, which usually happens in the setting of either aortic stenosis, or it can happen in the setting of severe hypertrophic cardiomyopathy, or if the patient is having severe LV systolic dysfunction. LV systolic dysfunction, where LV will try to contract for a longer period of time, and that is the reason why it happens, or very rarely it can happen in patients with aortic regurgitation, okay, especially if it is severe aortic regurgitation, because there is a lot of blood that is coming back into the ventricle during diastole in AR. The ventricle will contract for a longer period of time to eject this blood, excess blood that has come during diastole of the previous cardiac cycle. So that is why you might get a prolonged ejection, and because of that you will be having a paradoxical or a reverse split. Or one more condition if you want to say, which is an almost equivalent condition left bundle branch block, is RV pacing. Normally we pace at the right ventricle only in emergency situations. Whenever the patient is having RV pacing, that's also another characteristic condition which produces LBB pattern in the ECG, and you can understand. So that is the reason why it can result in the development of reversed split also. And narrow split, most of the conditions that produces reversed split, except LBB and RV pacing, which only produces reversed split. Apart from that, other conditions can result in the narrow split also, which means I told you in severe AS and HOCM, what happens is the A2 will be so prolonged, the ventricle will be contracting for a long period of time, that A2 will go beyond P2. But if it is not very severe, then probably like A2 can come closer to P2, so that you will have a very narrow split, not a reverse split. So apart from LBB and RV pacing, other conditions what I mentioned will be able to produce narrow split. So these are the causes of wide split, fixed split, narrow split, and we have something called as paradoxical splitting also. And there are some conditions that produce a single S2. Single S2, it happens in aortic stenosis, okay, where A2 may not be heard because the severe calcification and degeneration of the valve, A2 will not produce sound at all. So only P2 will be heard. Or in pulmonic stenosis, or in patients with transposition of great vessels, where you will not be able to see the P2 at all, only A2 will be there. Okay, so these are the conditions usually that produces single second heart sound. And by default, okay, your TOF generally tend to produce a single S2 only. Okay, TOF will produce only aortic sound, TOF will not produce a pulmonary sound, because there will be infundibular pulmonic stenosis or severe infundibular pulmonary stenosis will be there, and especially in severe case of TOF, only single S2 may be heard sometimes. So AS, PS and TJ will produce a single S2 only. I think we have exceeded the time. I'll take another session probably. Maybe I'll do it by March 1 or March 2. I'll do another YouTube session where I'll be completing on the third heart sound, fourth heart sound and the murmur part. So because that is something that is left. So we have covered the normal sounds. What are the abnormal sounds? Abnormal sound that is left is third heart sound, fourth heart sound, and we have some ejection sounds, ejection clicks, and then finally we have the murmurs. I'll try to cover that in the part 2 of the lecture. So hope you have had a good knowledge in this lecture, and I hope you learned something in this lecture. And with this, I'll try to stop the current session and let us see you in another YouTube session. Until then, stay tuned and have a nice time and study well. All the best.